Okay, I'm going to be talking about endometriosis today. My name is Jade Jones, and I'm going to jump right in. Endometriosis is an inflammatory, estrogen dependent disease that often results in substantial morbidity, pelvic pain, multiple surgeries, and infertility. It is characterized by the existence of endometrial glands and stroma outside the uterine cavity. Endometriosis represents a significant clinical challenge, commonly associated with significant morbidity and reduction in quality of life among reproductive age females. It is clinically defined as presence of endometrial-like tissue found outside the uterus, resulting in sustained inflammatory reaction. Early symptoms may be underappreciated due to lack of awareness by caregivers, health consumers, and clinicians, and timely diagnosis combined with effective management cannot be undervalued. Endometriosis is an enigmatic disease commonly associated with significant morbidity and reduction in quality of life among reproductive age females. Timely diagnosis and effective management of the disease represent a significant challenge for both clinicians and patients. Efficacious treatments require a multidisciplinary approach to effectively manage the wide-ranging symptoms commonly associated with endometriosis, including dyspareunia, infertility, and reduced quality of life. Um, there may also be marked distortion of pelvic anatomy. It is a leading cause of gynecologic hospitalization and hysterectomy. Efficacious treatment requires multidisciplinary approach. It is often called a disease of theories. The definitive cause or causes of endometriosis remains under debate, though demonstrated association with a number of hereditary, environmental, epigenetic, and menstrual characteristics exist. It corresponds to high association of comorbid conditions. And endometriosis also shares similarities with several autoimmune diseases, including elevated levels of cytokines, decreased apoptosis, and cell mediated abnormalities. The chronic inflammatory reaction, infertility, and pelvic pain associated with endometriosis may also correspond to the value in to a variety of comorbid conditions ranging from autoimmune diseases to food and environmental allergies and intolerances. The symptoms of endometriosis are ectopic pregnancy, pelvic infection, and ovarian torsion may mimic symptoms. Classic signs are severe dysmenorrhea, deep dyspareunia, chronic pelvic pain, clinical or perimenstrual symptoms. Severely compromised quality of life and sexual health are common with endometriosis. Classic signs include all that I just said. And women with endometriosis also frequently suffer from autoimmune inflammatory diseases, allergies, and asthma. Endometriosis typically develops on the pelvic structures, including the rectovaginal septum, the bladder, bowels, intestines, ovaries, and fallopian tubes. But it may also be found in distant regions, including the diaphragm and lungs, where it can induce catamenial pneumothorax, and rarely areas found far outside the abdominal pelvic region as the brain. The ovaries are among the most common of locations, with the gastrointestinal tract, urinary tract, soft tissues, and diaphragm following. Depending on the site, endometriosis may present with varied symptoms, including bowel obstruction, melena, um, dyspnea, dyspnea. I don't know how to say that word. I'm sorry. And swelling of the soft tissues. Um, a degree of disease present has no correlation with severity of pain or symptomatic impairment. Here are um, more symptoms. I'm sorry. as I stated before. So symptoms are wide-ranging and often start early in life, but they may be underappreciated by medical and lay communities. Symptoms may present as early as 8 years old, and high rates of disease and symptoms indicative of possible future endometriosis have been noted in adolescents and women based on recent prevalence data. The most common of the symptoms are what I just wrote out, what I showed you here. And some background characteristics of the disease described as far back as 1600 BCE. Investigators have attempted to reconstruct the pathway leading to the discovery of what we call today adenomyosis and endometriosis. Sorry, I lost my place. Knapp contended the disease was described well over 3 centuries ago, attributing credit to German physician Daniel Schroen. Schroen described a female disorder in which ulcers appear in the abdominal, the bladder, intestines, and inside the uterus and cervix, causing adhesions. Critics of these assertions, however, believe that Schroen's lectures referred instead to infections rather than endometriosis. In years following, other physicians would begin describing ectopic endometrial tissue in various cases, with the first histological description credited to von Rokitansky in 1860. Researcher Thomas Cullen later suggested that endometriomas, or as he called them, adenomyomas, strongly resembled the mucous membrane of the uterus. It is John Sampson, however, who is generally considered the forefather of the disease, with his work on the peritoneal and ovarian endometriomas, providing the first theory of pathogenesis. Emil Novak and other pioneering researchers in years to come would identify, refine, classify, and postulate on the sequela of pathogenesis and of the pathogenesis of the enigmatic disease known today as endometriosis. So there's no single theory sufficiently explanatory of the pathogenesis of endometriosis. Localized inflammatory process is supported by elevated cytokines and growth factor concentrations in the peritoneal fluid of the affected, and angiogenesis is favored in the establishment of implants. And there exist biochemical differences in the utopic and ectopic endometrium of women with the disease. These factors contribute to the pathogenesis and related symptomatology. Today, endometriosis has become a major clinical issue. There are 3 distinct disease entities, each with different pathogenesis: peritoneal, ovarian, and deeply fibrotic. So researchers agree that the disease is likely to be polygenic and multifactorial, but the exact pathogenic mechanisms are still unclear. Each theory singularly fails to account for all forms of endometriosis, thereby indicating multifactorial mechanisms. The development of endometriosis can be divided into 5 basic processes: adhesion, invasion, recruiting, and angiogenesis and proliferation. Genetics by biomolecular aberrations in the utopic endometrium, dysfunctional immune response, anatomical distortions, and a pro-inflammatory peritoneal environment may all ultimately be involved in the development. So for the epidemiology and the pathophysiology, about 176 million women globally are affected with are affected by endometriosis, and 775,000 from Canada, and 8.5 million in North America. Infertility is among the chief clinical findings. There's no known prevention of this disease, but it can be treated. Disease prevalence corresponds and increases with awareness and training of the surgeon, but is estimated to affect about 165 million women. Mistakenly believed to be a disease of older women. In actuality, nearly 70% of teens with pelvic pain are later diagnosed with endometriosis. Early intervention and increased awareness of the disease is requisite to reduce morbidity, infertility, and progressive symptomatology. Um, Variety and infertility have long been associated with endometriosis, with fertility among the chief clinical findings. So, infertility is usually the reason that people find out that women find out they have endometriosis. There's no known prevention related to a number of hereditary, environmental, epigenetic, and menstrual characteristics and alterations, some sharing certain common processes with cancer. The disease remains the third leading cause of gynecologic hospitalization in the United States, and it is considered a leading cause of female primary and secondary infertility. This disease is also a leading cause of hysterectomy in the United States, with a significant associated morbidity. The dioxin pollution has been suggested to be causally related to endometriosis based on the observation of increased incidence and severity of endometriosis in primates tested previously with dioxins. Related data suggests plausibility that dioxin exposure of specific timing and dosage may precipitate endometriosis through interaction with estrogen receptors, or suppression of progesterone receptors. Conversely, at least one recent study concluded that dioxin may in fact not contribute to the etiology of endometriosis at all. There's no clear association that has been defined between endometriosis prevalence and chronic immunosuppression. For example, in transplant patients, nor with smoking affecting NK activity, nor with caffeine or alcohol, nor with any lifestyle variable. Studies have found that higher body mass increases in it. Studies have found that higher body mass index decreases risk of both deep as well as ovarian and pelvic endometriosis, as does parity through pregnancy. Though pregnancy is not a cure. Frequency of endometriosis in women of higher social class has been reported, but this is likely the result of bias. The same diagnostic bias may explain the higher frequency in white women versus women of color. And in fact, data on prevalence in different races often do not consider the reason for admission for a surgical procedure, which may be selectively associated with the higher or lower likelihood of an endometriosis diagnosis. Few studies have evaluated comparable population and socioeconomic conditions. Those that did reveal no substantial differences among women of different races. Most recently, a provocative study by Vercellini and his colleagues determined that women with the most severe form of that women with the most severe form of the disease appeared more attractive to external observers than those with peritoneal and or ovarian endometriosis, as well as those without endometriosis. Women with severe rectovaginal endometriosis were judged to have a leaner silhouette, larger breasts, and earlier coitarche. Quatache, I don't know how to say that word. Authors did caution, however, that further studies are warranted to exclude a spurious relationship between attractiveness and rectovaginal endometriosis, and to rule out the potentially confounding effect of deep dyspareunia on some aspects of sexual behavior. On to infertility. About 50% of women with endometriosis may suffer from infertility. Assisted reproductive technology, male factors, and other factors are outside the scope of this module, but the focus herein is specifically on the role of endometriosis in infertility. Though the association is clear, mechanisms linking the two are uncertain. In general, biologic mechanisms connecting endometriosis and infertility could include distorted pelvic anatomy, including adhesions resulting from endometriosis, which can impair oocyte release or inhibit ovum pickup and transport, as well as damaged or obstructed fallopian tubes or acquired or congenital uterine defects. Altered peritoneal function, including increases in fluid volume, concentration of activated macrophages, prostaglandins, antibodies, lymphocytes, and ovum capture inhibitor, preventing cumulus fimbriae interaction, as well as endocrine and anovulatory disorders, including luteinized unruptured follicle syndrome, LUF, luteal phase defect, but in fact, it may be a cause or a cofactor in development of the disease. Impaired implantation, with evidence suggesting that endometriosis may be responsible for induced expression of the alpha beta 3 cell adhesion molecule during the time of implantation. While controversy surrounds the relationship between endometriosis and infertility, growing data strongly indicates alterations in the utopic endometrium of those women with this disease, which favor invasion and maintenance of the lesions. Next, I'm going to discuss the different ways to diagnose endometriosis and the difficulties. So, due to lack of awareness, endometriosis is often an underappreciated diagnosis. Women and girls with the disease suffer a delay in diagnosis, on average of 7 to 12 years. Let me start over. I'm sorry. An often underappreciated diagnosis. Women and girls with the disease suffer a delay in diagnosis, on average of 7 to 12 years, and may present to 5 or more physicians before their pain is addressed. Moreover, the disease may be mistakenly dismissed as routine menstrual pain, particularly in younger women. It is not possible to try to triage women with chronic pelvic pain effectively on history alone. Such women may benefit from referral to a specialist center for careful clinical assessment and appropriate investigation. The gold standard remaining laparoscopic pelvic examination, and where appropriate, peritoneal biopsy. In particular, data reflect that general practitioners' knowledge about endometriosis is limited, with possible direct consequences on the delay of the diagnosis. In survey findings, 63% of general practitioners indicated they felt ill at ease in the diagnosis and follow-up of patients with endometriosis. One half could not cite 3 main symptoms of the disease out of dysmenorrhea, dyspareunia, 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 chronic pelvic pain, and infertility. Only 38% of general practitioners indicated that they perform a clinical gynecologic examination of suspected endometriosis, and 28% recommended an MRI to confirm the diagnosis. In that endometriosis requires a surgical diagnosis, use of biomarkers has recently been described as the highest priority in the research due to continued lack of non-invasive diagnostic means. Lack of non-surgical markers contributes significantly to the delay in diagnosis and timely intervention, though proteomics and genomics are establishing the basis for future study related to biomarker development. Physical examination has poor sensitivity, specificity, and predictive value in the diagnosis of endometriosis. When probed, the patient may exhibit pain. A thorough combination of history, physical examinations, and laboratory and additional diagnostic studies, as indicated, must be done to determine the cause of pelvic pain and rule out other non-endometriosis concerns. The physical exam should include pain mapping, a helpful procedure used to identify location of pain with various diagnostic modalities. While some studies have proposed that uterosacral modularity is better palpated during menses, no studies have conclusively demonstrated this observation. However, hallmark findings of nodular masses along thickened uterosacral ligaments, posterior uterus, or the posterior rectovaginal septum may be present. Obliteration of the cul-de-sac in conjunction with fixed uterine retroversion may also imply extensive disease. Rupture of an ovarian endometrioma may present as an acute abdomen. Extensive involvement of the rectum and other areas of the gastrointestinal tract may also cause adhesions and obstruction. And absence of evidence during the exam is not evidence of disease absence. So just because the exam didn't show a certain ulcer or what have you does not mean the disease is not there. Imaging studies are helpful, but not drawn back with are not without drawbacks and limitations. MRIs may detect even the smallest of lesions and distinguish hemorrhagic signal of endometriotic implants, superior to CT scan in detecting limits between muscles and abdominal subcutaneous tissues. Transvaginal or endorectal sonography may reveal ultrasonographic features varying from simple cysts to complex cysts with internal echoes to solid masses, usually devoid of vascularity. CT may reveal endometriomas appearing as cystic masses. However, appearances are nonspecific, and imaging modalities should not be relied upon for diagnosis. Surgical diagnostic and diagnosis and staging. Laparoscopic intervention is primary means of definitive diagnosis. Clinically visualized findings may represent tip of the iceberg. And though glands and stroma represent gold standard diagnosis, fibrosis in combination with hemosiderin laden macrophages macrophages may be sufficient for presumptive diagnosis. Laparoscopic intervention. Yeah, I'm sorry, let me go back. It is the gold standard. A histologic confirmation of both endometrial glands and stroma in the biopsy specimens is required to make diagnosis. Due to the subtle appearance of some implants, accuracy of diagnosis depends on the ability of the surgeon to adequately identify the disease. A thorough systematic examination of the pelvis and abdomen is essential in all patients to identify and document all lesions, with care taken not to overlook peritoneal pockets and ovarian foci. So there are two main types of treatment for endometriosis. There's surgical intervention and non-surgical therapies. So back to the laparoscopy. When endometriosis is diagnosed at the time of surgery, surgical destruction of the disease is recommended with the objective to remove endometriotic lesions, preserve uterus and ovarian tissue, and restore normal anatomy. This may be achieved through standard or robotic-assisted laparoscopy. Rarely is open to laparotomy indicated. Although excisional surgery offers a high success rate in treating the disease, excision also requires a higher level of surgical skill. As a result, many patients receive incomplete treatment by less experienced surgeons, which in turn may lead to persistent symptoms and recurrent disease. It should be noted that women who have undergone repeated surgeries and have had a hysterectomy still suffer. They need to improve the need to improve surgical approach and or engage in timely referrals is unquestionable. Surgery to debulk and excise endometriosis may be more difficult than for cancer. So, complete removal of implants may be difficult due to variation in appearance and visibility. Lesions may present as powder burn implants, which are microscopic disease may be identified in otherwise normal appearing peritoneum by light and electron microscopy. Complete excision of endometriosis, including vaginal resection, offers a significant improvement in sexual functioning, quality of life, and pelvic pain, including in those symptomatic patients with deeply infiltrating endometriotic nodules in the posterior fornix of the vagina. As well, the technique offers good results in terms of reduced bladder morbidity and bowel symptoms. Again, however, this kind of surgery requires uncommon surgical skills and anatomical knowledge. It should be performed only in selected reference centers. In general, laparoscopic excision significantly improves general health and psycho-emotional status at 6 months from surgery, without differences between patients submitted to intestinal segment resection or intestinal nodule shaving. Pain, sexual function, and quality of life improved significantly and were associated with a good fertility rate and a low complication and recurrence rate after a carbon dioxide laser laparoscopic radical excision of endometriosis with the colorectal wall invasion combined with laparoscopic segmental bowel resection and reanastomosis. Randomized controlled trials also demonstrate the randomized controlled controlled trials also demonstrate that excision is also associated with a higher pregnancy rate and lower rate of recurrence, though it may cause injury to the ovarian reserve. Improvements to this aspect may be represented by a combined excisional vaporization technique or by replacing coagulation with surgical ovarian structure. The primary goal of medical suppression is to impede the growth and activity of endometriotic lesions. The high rate of recurrence, the high rate of recurrence suggests that a combination of surgical and medical management might provide maximized outcomes, and any of the agents can be used before, after, or both before and after either conservative or radical surgery. All have similar clinical efficacy. I can never say that word. I'm so sorry. In terms of reduction in pain-related symptoms and duration of relief. So some medical therapy, superficial surgical, and medical treatments often fail. Side effects may be intolerable for some. Symptoms recur upon cessation of therapy. Selection of medical therapy depends on therapeutic effectiveness, tolerability, drug costs, physician experience, and expected patient compliance. So in conclusion, despite receiving very little mention in historical compendiums of disease, it remains without question that endometriosis has impacted lives of women for centuries. The disease remains even now a chronic, costly illness requiring long-term, multidisciplinary treatments. Endometriosis, a complex disorder that may go undiagnosed for years with no absolute cure and high recurrence rate, continues to be a significant reproductive health concern with highly negative and far-reaching effects. The profound economic impact and significantly impaired quality of life of the affected contribute to the urgent need for continued research and improvement in diagnostic and treatment modalities, and focus on better clarifying pathogenesis and pain mechanisms, as well as linked to certain morbidities, for example, malignancies and autoimmune disease, is necessary. Though prevention remains elusive, increasingly sophisticated research efforts will lead to more timely intervention and appropriate multifactorial treatments to restore quality of life, preserve or improve fertility, and lead to long-term effective management of this enigmatic disease. And here's a picture of, on the left, a normal view of the uterus, and on the right is the fallopian tubes are affected with endometrial tissue, as you can see. And that concludes my presentation. Thank you.